start today with the first speaker, Dr. Refaai. Dr. Refaai is the professor of pathology and laboratory medicine at the University of Rochester Medical Center in Rochester, New York. Um, he is the director of thrombosis and hemostasis lab. He is also associate director of blood bank and transfusion medicine, as well as associate director of therapeutic apheresis. So along with his all clinical administrative duty, he is a prolific researcher. His research focus are on the in vitro and in vivo effects of ABO antibodies and ABO immune complexes on platelet function, coagulation, and endothelial cell integrity. He has published more than 130 reviewed articles and book chapters. And today he's going to talk about why does blood transfusion results in tissue hypoxia. So I'd like to welcome Dr. Refaai.
Thank you very much for the nice introduction, and thanks for having me, and thanks for the BMSS to organize this nice meeting. So the entire idea of this presentation is: are we doing any good for the patient when we transfuse them red blood cell? The objective of my calls is to describe the oxygen hemoglobin dissociation curve, talking a little bit about the storage lesion of the red blood cells, and understand that red blood cells transfusion effect on tissue oxygenation. So for the last couple of days, you heard a lot of talks about anemia, and it's the most common disorder worldwide, actually, from west to east to south to north. You can see between 3% of the population to almost 40% of the population, depending on which data you're looking at. But this is data from 2018, and you can see how prevalence is anemia worldwide. Luckily, hopefully it's luckily, I'm not sure about this, but the iron deficiency anemia is the most common anemia worldwide. Even in the ICU patients, the frequency of anemia is almost 8%. It's been published recently. Blood transfusion usually used in these patients, unfortunately, especially if it's in elective situations sometimes, they use the transfusion to support the anemia instead of fixing the anemia before the patients got admitted. Which in their criteria, they are supporting the hemoglobin. They're increasing the hemoglobin to support the oxygenation. Although the red blood cell could be a life-saving, as we know, in massive bleeding or in traumas or in patients dependent on transfusion, but it doesn't come with no risks. So risks could vary in severities and could include a lot of complications, as you can see here on the screen, from hemolytic reactions to allergic to non-hemolytic reactions, febrile non-hemolytic, circulatory overload, trolley infection, and ongoing. So when we store red blood cells in the blood bank, there's a lot of things going on the blood bank, on the stored red blood cells. Could be metabolic, biochemical, or even molecular changes of the red blood cells, and even change in the shape of the red blood cells. And the significant ones include also the drop in the ATP and the 2,3-DPG. These are the most significant ones that affect the oxygen delivery. This is just like a most recent data, kind of like a collection in one review of the entire changes happening during the storage, the consequences on the red blood cells, and even after the transfusion in the patient. And I'm not going to go through this. Definitely, it will take me more than an hour this morning. But I'll leave this just for your entertainment, just to go through it. I really like it because it's really linked each changes to the outcome of the transfusion. If we go back at beginning of the 2002, actually, a study was published showing the changes, the electronic microscopy changes of the red blood cells during storage. And as you can see at the beginning, which is around the first week, you can see the dominant discocytes red blood cells. I mean, this is a very normal red blood cells. Moving forward, couple of weeks, it starts to get less and less, and more of the echonocytes. Echonocytes has a couple of issues here. First, it does not move very well in the capillary system of the body, of the circulation, and also does not release oxygen easily. So this is just for the changes of the membrane of the red blood cells. By the expiration, by 42 days, you rarely can see any of the discocytes red blood cells, any normal red blood cells you're comparing to the first week. This is just to show us what exactly happening. We know that a lot of things happen during the storage, but I was not anticipated to see this within the first few hours. Like, look at the pH, how it dropped, and look at how significantly the 2,3-DBG drop was in the first few hours. And by the 24 hours, it's almost about, I would say, 30 to 40% less where we started. By 2 weeks, you basically almost close to undetectable. And this is very important in binding and releasing the oxygen to the tissues. Oxygen saturation, that means that the more oxygen will stay in the red blood cells, and that's increased significantly over the storage. This is another study, was to show us and to compare between whole blood versus suspended red blood cells. And they studied the 2,3-DBG, and as you can see, it decreased significantly within the first week. This is another study to show us how significantly it does decrease. By almost the fourth week, third to fourth week, it's like very, very low and almost non-detectable. And the oxygen release, which depends 100% on the 2,3-DBG, as you can see here, also dropped accordingly with the same time of the dropping of the 2,3-DBG in this study. This is not new. This is not fresh or not just recent. Since 1969, and even I found studies from 1954, to be honest with you, but I wasn't able to get the article or even to get a shot of the first page. They were studying and they were anticipating that there is some changes on the red blood cells when we store it, and these changes affect the patients after transfusion. And what they found in this study, they studied the 2,3-DBG in the stored red blood cells, and they saw that it strongly depends on the pH of the red blood cells. And then they investigated the level of the 2,3-DBG and ATP in stored red blood cells, incubated in fresh plasma. So they took red blood cells, stored red blood cells, and incubated in stored plasma, in fresh plasma at 37 degrees with a normal pH, to stimulate the condition after what happened with transfusion. And they saw that the ATP level remained relatively stable under these circumstances, and the 2,3-DBG start to gradually increase. But almost after 8 hours, only 1/3 of this 2,3-DBG was repleted, so it was increased in the red blood cell incubated with a fresh plasma. So their conclusion was stored red blood cells may fail. I mean, they did not have a lot of technology at that time to help them drive this conclusion, but they said it may fail the oxygen, transporting oxygen efficiently to the surrounding tissue, even to the tissues, even after several hours of transfusion. The measurements of O2 delivery and consumptions taken before and after red blood cells revealed decrease in P50, and this P50 is like the 50% capacity of the hemoglobin to carry oxygen. And that's likely to increase the affinity to the hemoglobin. So when you, as you're going to see in the next few slides, when you look at this oxygen dissociation curve, you'll see there's a little bit change of the V50 will allow the hemoglobin to capture or to increase affinity to the oxygen. And that's reduce the transportation of the oxygen to the tissue. Another study was done in 2011 by Dr. Sadak et al. They studied these changes of the microcirculation in sepsis patients after 1 or 2 red blood cell transfusion for a hemoglobin between 7 to 9. They measured the oxygen saturation in thinner tissue, and to be honest with you, although I'm a pathologist, I don't know where are these thinner tissues, is the three muscles at the base of your thumb. So they used a tissue spectrometer, and also a vaso-occlusive test was performed before and 1 hour after transfusion. And they saw no significant changes in the muscle tissues after 1 hour of finishing transfusion. This is what they found. They definitely, and this was, as I said, what's 2011. They saw an increase, significant increase in hemoglobin. They did not see any changes in any of the oxygen parameter that they measured in these patients. And even with the this is called the flow of the oxygen. So this is the inspired oxygen versus the saturation of the oxygen in the circulation, and they did not find any changes during the 1 hour after transfusion. Weinberg et al. Also studied the muscle tissue saturation in trauma patients after transfusion of older red blood cells to explore the effect of the storage lesion. And saturation was measured continuously by near-infrared spectroscopy during the course of the transfusion of only 1 unit. Pre and post perfused capillary vascular density was also determined, and they found that a decrease in muscle tissue oxygenation and the perfused capillary vascular density, which was associated with the transfusion of older red blood cells. So the more the older red blood cells, the less oxygenation also would happen. And this is the graph they show us, that they start decreasing in the oxygen saturation even after 1 week. But when you get to the final, the 35 or 42 days, basically it was significant difference in the oxygenation. This is the normal oxygen dissociation curve. As you can see, there's a lot of, this is how the oxygen gets bind and released to the tissues by the red blood cells, the normal one. And the stored red blood cells usually get affected to the left shift. And that's due to the increase, the decrease in pH, decrease in 2,3-DPG, and the P50. So a little bit of change in the P50, as you see, it will cause this shift to the right or to the left. So that will bring me to our study. So we did a study, it was published last year, and we wanted to study the effect of the red blood cell transfusion on the peripheral capillary oxygen and the PaO2, which is the partial pressure of the arterial oxygenation. The aim, as I mentioned earlier, was to evaluate changes in oxygen standard parameters in adult patients before and after red blood cell transfusion. It's not easy to be done in adult patients, and it's not easy to be done in patients who are basically measured their oxygenation or assess their oxygenation. So we have, besides that, despite improvement in hemoglobin levels after a blood cell transfusion, the high affinity for the transfused hemoglobin or for the transfused blood cells hemoglobin will decrease due to the almost non-detectable 2,3-DPG. And that will result in a decreased PaO2 and SpO2, which will affect the tissue oxygenation. So to evaluate the oxygen delivery, we use the two parameters, the SpO2 and the PaO2. SpO2 is a peripheral capillary. Usually you see it in the ICU patients when they did the detector on their tips of their fingers, and also the pressure of the dissolved O2, which done by the arterial gas analysis. And the SpO2 measure indirectly the hemoglobin saturation of these tissues, and PaO2 reflect the O2 uptake by the blood. So selection criteria was a little bit of a challenge here. So it's as you know, it's a single center retrospective observation study. So we included patients of 18 and more, hemodynamically stable medical ICU patients, routinely monitored by either SpO2 or both of them, or PaO2. Received only 1 red blood cells over a period of 36 hours, which will be about 12 hours before transfusion and 24 hours after transfusion. So we consider the transfusion as a time zero. Indication for red blood cell transfusion was specifically for hemoglobin level correction. That's what we received in the order, in the blood bank when they ordered the unit. And the transfusion definitely met our guidelines, which is hemoglobin of less than 7. Oxygen therapy and also mechanical ventilation were included in these patients. We excluded any active bleeding. We excluded patients undergoing medical procedures, transfusion of more red blood cells, and also transfusion of any other blood products. And also if the patient's transferred to a different unit or outpatient of the ICU. So imagine this in an ICU patient. It took us a while to just get what our number, which wasn't that's a significant number, as we're going to see later on. So patients were identified through our blood bank medical records. So that's how my residents and my fellow started to track these patients from the blood bank records when they ordered these units. And then we collected the data and analyzed it. So patients who met the inclusion criteria, we between May 2018 to February 2019, about 10 months, we assessed the hemoglobin, SpO2 and PaO2. We also assessed the oxygen support, the amount of oxygen flow and concentrations during that period, during the 36 hours. The start of transfusion, as I said, was considered time 0, and data were collected and analyzed at 4 hours intervals, 12 hours before, 24 hours after. Storage days of the red blood cells. Also, we looked at this just to see if that will change any of these parameters. And then any relevant data from the medical record, as you can see here. So out of 267 patients that were kind of eligible for these criteria, for this study, only 106 patients were included because of the full data. And we separated them into 2 groups, the SpO2 and the PaO2. The mean age, as you can see, was in the 50s. 58% males. The primary diagnosis was 44% cardiac disorders, hematological diseases about 17%, and pulmonary disorders about 10%. Therapy was required. Oxygen therapy was required in almost 3/4 of these patients. 68% were intubated on mechanical ventilation and required oxygen level of about 47 plus minus 10. 28% were on a nasal cannula with about 5 liters per minute of oxygen. 4% required another form of delivery of the oxygen. This is when we compare this SpO2 between the beginning and over here I just choose 4 hours just to make it small, make the curve a little bit better, but there were no major changes here before the 4 hours. So this is when we transfuse the red blood cells. And as you can see here for the SpO2, this is our patients, 78 patients. The minute we transfuse red blood cells, by almost finishing the red blood cells, which could take between 2 to 3 hours, 4 hours sometimes, you can see the significant increase in the hemoglobin, which everybody knows this, but we improving oxygen. But you can see a significant drop here in the SpO2. Now, I'm not saying significant clinically. Difference between 96 and 98 or 97.5 is not that great clinically. Patients usually the range of normal is between 92 to 100 or 99. It's not a big deal, but it did not meet the idea of the transfusion. I mean, we are transfusing to improve oxygenation, okay? And when we see this, it's really something really strange. What happened here? And that's continued even after 24 hours. I mean, we were at the previous studies, and even for the people who reviewed our paper and commented on it, they said, yeah, we know, but after a few hours, the 2,3-DPG does improve. We saw from that study, like almost even after 8 hours, only 1/3 of the 2,3-DPG was detected to come back to normal. So basically, within even 24 hours, we're still not improving oxygenation. And this is not only in this in the SpO2, but also in the PaO2, as we're going to see later on. So hemoglobin increased significantly. Average increase was up to 1.2 grams per minute for almost 24 hours. SpO2 within 4 hours did not change, and also through the 24 hours did not change. PaO2, again, as you can see here, not much different before the 4 hours. This is the time of the transfusion. and how they shifted here. Now, let me just explain a little bit about the PaO2. I'm not sure if everybody's familiar with it or not, but just to remind you that PaO2 is basically the oxygen concentrations in your arterial blood. So when it's going down, that's mean the oxygen is maintained inside the red blood cells. It's not released. It's not soluble. So that's what happened. You need more soluble oxygen. We need to see this going up here, because when the patient is taking oxygen through a ventilator or through a cannula or whatever, the oxygen in his blood should increase. That means it's more soluble oxygen in their arterial blood. Unfortunately, we are seeing the opposite here. Okay, and that's after the transfusion. If we left the patients with no transfusion, he may stay at this level. He may actually doing better than the transfusion. So it was significant over 24 hours. So the oxygen requirements were variable among patients throughout the study, but almost 20% of the ventilated patients required increased oxygen after transfusion. And we did see this in their charts. So this is a significant number. 20% of the transfused patients required more oxygen. 40% of the cannula oxygenation required also an increase over the 24 hours after transfusion. So indication of potential lower tissue oxygenation and lower soluble oxygen following a single red blood cells. We only included one red blood cells, remember. So during the study, no acute deterioration was observed in any patients, and if so, we eliminated that data. We did not include that patient just because we want to have as much as possible clean data. Red blood cells were either incubated in CBD or additive, and was like 35 or 42 days. But however, the average transfusion was similar to the national average, actually, which in about 17 plus minus 2 days. No association was observed between the age of the red blood cells and the oxygen parameters. And this is, again, only because it's not significant numbers. I mean, according to our statisticians, we need at least 500 to 600 patients in order for us to check on the red blood cells age. And we did not have this in our patients. The primary aim of the red blood cells transfusion and hemodynamically stable anemia patients is generally improve the hemoglobin level and enhance the tissue oxygenation. As we know, this is a general reason for transfusion. I want to improve my patient's hemoglobin and his oxygenation. Clinically, it's assumed that the decreased 2,3 dBg in the red blood cell is transient and usually replace their 2,3 dBg. Red blood cells replace their 2,3 dBg deficit shortly after transfusion, or however, multiple studies show us the opposite. The significant decrease in PaO2 in our study is an indication of binding of soluble O2 to the hemoglobin to the transfused red blood cells due to the increase in affinity for oxygen. And the decreased SpO2 demonstrate the reduced capacity for O2 delivery to the peripheral tissues. These changes were observed in hemodynamically stable patients over 24 hours and after transfusion of one red blood cells. And the question I want to ask here, what would happen if some patients receive more than one red blood cells? What would happen if some patients receive having some bleeding at the same time? Bleeding, that means he's losing his good red blood cells with good hemoglobin. And what happened in patients, in pediatric patients? There's some limitations. There are some limitations for this study. It's a retrospective data collection, only one red blood cells, including hemodynamically stable patients, to minimize, as I said, the possible interacting conditions and to better understand the oxygen transportation with this red blood cells. Currently, we are in the process of conducting a similar but prospective study on cardiac surgery patients population. And with this, I'll stop my presentation here. And I'm open also, by the way, for we are working with the IRB right now to start this study with pediatrics. I'm just going to take a couple of seconds to say that if anybody interested, I would love to do this as a multi-center study. So just let me know, and we can definitely work together to establish this. Thank you very much.